This is the first, this is a scleral fixation IOL video presentation. This is a dislocated cataractous lens. 3-port vitrectomy was performed as much possible, thorough vitrectomy, so that there should not be any element of vitreous at and around the SF IOL. Actually, total vitrectomy is desired in such cases. Now we have to mark the it should be precise 180-degree apart, and 2 mm paralimbal needle track is marked. This is a Yamane technique for the fixation of foldable IOL, 3-piece IOL. Now the main incision is taken for the lens to implant. The problem with such type of eyes is the hypotony. So you have to maintain the volume. That's why irrigation port is very important. This is the loading of the lens. 3-piece lens is preferred. This is the needle track we have made, 2 mm away from the limbus. It's a bent 26 gauge needle I prefer. I tried 30 gauge needle, but it's very difficult to load the haptic. Sometimes it's stuck into the needle track. The leading haptic I just inserted in the needle track. It's a little tricky. With experience you learn all those techniques. I find it's very less invasive technique. Learning curve is there, but you can learn very well if you are a good vitreoretinal surgeon or a good phaco surgeon also. This needle is taken out and slowly you have to just take out the haptic. Then you have to cauterize the end of the haptic, and now this is the rare haptic. It's very difficult to take out this haptic from the second port. Many times you can your lens can drop down, so you have to be little cautious and do the things delicately. The centration is very important, otherwise you can get different type of astigmatism, tilting and all those things in lens. This is second case again, is a second haptic or the rare haptic we have catch hold of, and with the second needle I have taken out slowly, delicately. Manipulations are there, but if you are well versed with the technique, you can develop your own techniques. There are many modifications they have made by different people. They take out the needle outside the main incision and then load it. So whichever way you feel better for your surgical skill, it allows you can adopt that. So this is the second case, again the same technique. 2 mm away from this, marking are important. Thorough vitrectomy is very important, and hypotony should be taken care of by the irrigation. Generally I prefer 3-port, so it is easy to do all those things. Visco for the protection of endothelium, many times is a second procedure. You have to take care of endothelium also, and in also scleral fixation IOL, chances of endophthalmitis are also there. So sterile precautions and other things should be taken care of. You can use Vigamox intracameral. The leading haptic is not much problem because you can slowly take it out, make a terminal bulb. Only should not get slipped out, otherwise it will be haywire. but very less invasive. And secondly, you will see clear cornea, lens, well center lens, and good vision. So outcome is very good. Out of all um, secondary IOL, whatever I perform so far, I find this best. But it is little tricky, and you have to have learning curve. The rear haptic really difficult. So I bend the needle little bit at the tip also. I modified my own technique, and I feel it very easy nowadays. So this is the rear haptic, which is again cauterized and centration is achieved. This is the schematic model, how it is done, very well shown. Sensor and this, I think Alcon have got these type of lenses. They are very good. Likely complications, again glaucoma, pressure rise, inflammatory, post-op inflammation, corneal edema, chances of infection are there. So you should be very particular during surgery only, and preoperatively also you can start antibiotics so that infection chances are less. So in the second talk I will go through. Any question on this?
What is the model eye which you have used?
No, I have not used it. It is online. I have just selected one.
So any comments, ma'am, for this Yamane technique?
I have not seen the exact technique as of now, because whatever I have seen is being shown very nicely. I think what is the rate of falling this IOL into the vitreous with this kind of technique? Is there any incidence for that?
Yeah, initially when I started, once or twice it happened. But being a veterinary surgeon, we can take it
That's
out. Yeah,
very easy.
yes. But initial days it is difficult to learn.
There are nowadays new IOLs have come with the haptic design, so that there is a thicker end of that haptic,
Yeah.
and we can easily take out by some special instruments, and it tucks very nicely there.
Yeah, that's true. But ma'am, that opening is very large. That is the
that
only
has to be,
concern.
yeah. Small opening should be made,
Yeah.
and then it is taken out by folding it, and then it opens up there.
Yeah. That's
So the
also
main
no, nothing. Post-op, nothing. Because it is just 26 gauge, and that too tangential. Na? That's why there is no hypotony.
And how long you have to follow up, like any use on?
Yeah, quite 1 year, 1.5 year, no problem. Only pressure rise is there sometimes, secondary glaucoma. So with medication that can take care of.
So what I feel is that it is a excellent technique, but with all techniques there is a learning curve, and which can be steep sometimes in some hands, when some people can pick up fast, but definitely there is a learning curve. And in the initial period you will have haptic breakage, trauma to the iris, hyphema, vitreous hemorrhage, glaucoma, hypotony, retinal detachment, whatever you name, no technique is perfect. So this is one of the options which we have for the rehabilitation of aphakia. So whichever technique is comfortable, we have to do. In this technique, the key points are that you have to be 180 degrees apart, and initially 2 millimeter was suggested, but 2.5 millimeter is slightly better, because it is slightly away from the iris. So touch with the iris of the IOL and pigment dispersion, and those things will be reduced by this. And the IOL power should be around emmetropia. Instead of reducing the IOL power, we have to keep the same power as the capsular bag. Whatever your IOL master shows, the same IOL power should be selected, and you implant it at 2.5 millimeters. Use the least possible diameter of the needle. So the ideal needle is 30 gauge thin walled needle. Short of that, 27 gauge needle is available, so that is better than the 26 gauge. So with these, most of the times you will be able to do it nicely. Yeah, Swapnish.
So most of the time there is a IOL top, and we have to create a SICS tunnel. So does that make your surgery easier, and any modifications that you do? And second question is, if it is a large myopic eye, is it possible to do a vertical kind of, like how there is a vertical glued IOL, because then the white to white diameter is too
Yeah, in such cases we can modify our technique. You can make vertical also, but I didn't come across such complication. Only once IOL drop was there. Drop means only one haptic was slipped down. Then I could catch that and again reinsert it. So I didn't find much of a problem. In initial days it happens. So you have to be ready with all the plan B.
And instead of a clear corneal, if there is a SICS tunnel,
SICS tunnel for removing the IOL.
IOL, because on
Yeah, yeah. For removing the IOL, you can use the SICS if it is dropped down.
do you use the same tunnel for doing the MRI then, or you create a free
A different tunnel because clear SICS tunnel you have to make, na.
for putting the, like how you showed,
Uh-huh.
you use the injector through a clear corneal?
Yes, yes.
See, we can use a, when you have a large incision, you can use a rigid 3-piece IOL. That is also available.
Yeah, that's
So
available.
from our lab, you have got a rigid 3-piece IOL. If you have a large incision, you may opt to put use that same incision to put a large diameter IOL. And if you have got a hydrophilic or hydrophobic IOL and there is no preoperative astigmatism, then you can cut the IOL and explant it outside, and through the same incision, you can put a foldable IOL. So it depends on the astigmatism and the IOL which has been dropped inside. If a 3-piece IOL has dropped, you can use the same IOL to fixate. There is no need to exteriorize it. You can use the same IOL. If it is a non-3-piece IOL, then obviously it has to be removed. Yeah, you can go for the next.
So this is the
But in cases
I am
of
Dr
like
Santosh
malformed,
Agrawal. I am
malformed
going
chest,
to
how do you
present
say
a
that?
innovative technique,
has
modified
sound
technique
actually.
of OPDFG that I
Hello?
call as
Which incision?
OTFG. Now, in this
No, the
video,
incision
using
totally
a
depends
26
on
gauge
the
bent
surgeon's
needle through
choice.
the
In
sclerotomy
Marfan syndrome,
इसमें sound
if
भी है.
you can
Voice
use
on,
any,
voice on है.
you can use
Voice
the
on.
routine
Because
foldable
many,
IOL
many a
incision.
times we are getting the subluxated IOLs,
Starting.
subluxated lenses.
Yeah.
So how do we do
Dr.
it?
Santosh
If we have
Agrawal.
to
I
select
am
this
going
kind of.
to present a innovative